There are three elements to airway management. Number one, the patient. Has your assessment identified their risk of difficult mass ventilation or difficult intubation, or having a reduced safe apnea time, that is the duration of apnea before oxygen saturation begins to fall? Number two, the situation. Emergency situations have increased risk of airway problems. And also the location. Any location other than the theatre suite, for many reasons, presents an increased risk of airway problems. The third factor is the clinician. How experienced are they? How good is their communication? And what is the skill and confidence of the team surrounding them? The purpose of the airway assessment is to answer some key questions, the most important of which is, will I be able to perform mask ventilation effectively? Difficult mask ventilation occurs in 5% of patients. Inability to perform mask ventilation is a life-threatening emergency. I can't really emphasize enough how important it is to have a reasonable answer to this question. Another very important question is, what is the safe apnea time likely to be? That is, after pre-oxygenation, are there factors present which make rapid desaturation more likely, like obesity, sepsis, pre-existing cardiovascular disease or respiratory disease, and pregnancy? Your third question is, will I be able to perform laryngoscopy, either direct or video? And if I can, will I be able to intubate the patient? Are there things that might make it difficult? Fourth, is there a significant aspiration risk? Finally, is there any reason to do an awake intubation? And in extreme cases, can I access the cricothyroid membrane if I need to? How do you answer these questions with your assessment? First of all, if there's a past anaesthetic record or an airway alert form, that will give you a lot of information. Then consider whether the patient has any acquired problems that interfere with their airway, such as rheumatoid disease, ankylosing spondylitis, reducing jaw and neck mobility, any trauma, facial fractures and associated swelling, infection, dental infection, upper airway infection, tumours, upper airway tumours, thyroid tumours. ENT tumours can change very rapidly in a short space of time. So even if they've had an anaesthetic 2 weeks ago, things can change quite significantly in that time. Irradiation to the upper airway and neck, as I mentioned, is the most significant predictor of impossible mass ventilation. The tissues become fibrosed, fixed and woody, and nothing moves. Hemorrhage, bleeding into the upper airway, post-operative bleeding into the neck, i.e. after something like thyroid surgery, is a consideration. Chemical and thermal injury can cause tissue damage and swelling, and very commonly now, patients with beards. Beards can make forming an airtight seal with a face mask difficult or even impossible, and it is actually a really significant consideration in your pre-op assessment. Some congenital problems can make airway management difficult. These may be simply anatomical, like a receding mandible or a marked overbite, or they can be congenital syndromes like Pierre-Robin syndrome. Obesity is relevant in several ways. The safe apnea time is reduced in people with obesity. That means even after pre-oxygenation, desaturation can occur significantly quicker. The distribution of body fat should be considered, with fat deposition in the parapharyngeal tissues, meaning there's increased airway collapsibility, predisposing to obstructive sleep apnea. Please note that the presence of OSA, or snoring without apnea, or neck circumference increasing above 40 centimetres are associated with an increased probability of difficult mask ventilation. You should do a pre-op airway examination, so look at mouth opening, how wide can they open their mouth, how big is the tongue, what's their Mallampati score, which we'll discuss later. Have a look at their teeth. Having teeth makes bag mask ventilation easier and intubation a bit more difficult because there's less room. Isolated teeth can make inserting a laryngoscope or a tracheal tube awkward, and loose teeth may be at risk of loss into the airway. Ask the patient to move their mandible forward. Poor jaw protrusion is a predictor of difficult mass ventilation. Have a look at the shape of the jaw too. Overbite or receding mandible may make intubation more difficult. Neck movement should be assessed as part of the patient's ability to achieve the sniffing position, that is flexion at the neck and atlanto-occipital extension for both mass ventilation and laryngoscopy. And you might want to palpate the submandibular space for tissue changes, particularly if there's a history of irradiation or infection or burns. Non-compliant tissue in this area restricts the effectiveness of basic airway manoeuvres, resulting in difficult mass ventilation. There are specific airway assessment tools which help to build up an overall picture, but in themselves lack sensitivity and specificity, and they're only really of value if the measurement is accurate. So the first one is mouth opening. An inter-incisor gap of less than 3 centimeters is a cause for concern. Some video laryngoscope blades need as little as 2 centimeters for insertion, but manipulating the blade might still be difficult, and insertion of supraglottic airway devices, i.e. laryngeal masks, may be difficult too. The Mallampati classification is used a lot. It assesses the size of the tongue and the oropharyngeal cavity size and their relationship to each other. It's carried out with the patient sitting, opening their mouth and protruding their tongue as far as they can, and there's a score of 1 to 4 depending on the anatomical structures seen. Classes 3 and 4 should alert you to the possibility of difficult mass ventilation and difficult direct laryngoscopy. However, Mallampati has poor inter-observer reliability, and it's got a poor positive predictive value if it's used alone. The thyromental distance is the distance from the upper border of the thyroid cartilage to the tip of the jaw, measured with the head in extension, and a distance of less than 6.5 centimeters is associated with difficult direct laryngoscopy. Sternomental distance is the distance from the sternal notch to the tip of the jaw with the head extended, and a distance of less than 12.5 centimeters is associated with difficult direct laryngoscopy. What you can see at laryngoscopy is described by the Cormack and Lehane classification, grades 1 to 4, with grade 2 being divided into 2A and 2B. You can pause the video and have a look at the descriptions rather than me describing them to you, and I'll show some photographs of the classifications on the next slide. The difference between a grade 2A and a grade 2B is a bit in the eye of the beholder, but certainly seeing minimal part of the glottis and possibly only the arytenoid cartilages would make the grade a 2B. If you can't see what you want to see, you can ask the anaesthetic assistant to apply burp. They'll know exactly what you're talking about. It means backwards, upwards, rightwards pressure on the larynx, really the thyroid cartilage, and it can improve the Cormack and Lehane classification by a grade or so. It can also be used just to move the glottic opening into the right position as you advance the tube, or a bougie if they're not lining up properly.